Hello, everyone. We have very interesting discussion today with question and answers regarding the nutrition in CKD patients. I'm Dr. Amr El-Husseini, a professor of nephrology, and I have Dr. Aliaa El-Ghamrawi, which is a specialist nephrologist from Egypt, and she's going to help me to answer some of the question regarding CKD and nutrition. The first question is, which one of the following statements regarding nutrition in kidney disease patients is incorrect? So choose the wrong answer. The first option is an individual with undernutrition are at risk for protein energy wasting. The next one is individual with undernutrition are at risk for micronutrient deficiencies. Third one is inflammation, acidosis, insulin resistance would worsen malnutrition. The option number D is micronutrient, vitamin, trace elements, electrolyte deficiency may occur because of inadequate dietary consumption, reduced absorption, and renal replacement therapy. The last choice is protein restriction might improve malnutrition and quality of patient's life. Which one of these statements, Aliaa, is incorrect?
I think E is incorrect, but the four first distractors are correct. They all happen with malnutrition. However, protein restriction improves malnutrition and quality of life. No, it has to be balanced, between around 0.8 grams per kg.
Very good, very good. So the wrong answer is protein restriction. Of course, it doesn't improve malnutrition. Actually, especially marked or severe protein restriction would worsen the malnutrition and also the quality of life of our CKD patients. So patients with CKD are at increased risk of malnutrition and protein energy wasting. And understanding this problem and addressing this issue is very important to improve our patient quality of life and survival as well. And undernutrition doesn't only include protein energy malnutrition, but also micronutrient deficiencies. So they have deficiencies in vitamins, trace elements, electrolytes, especially dialysis patient, because some of these trace elements also and the micronutrients are removed during dialysis. In CKD prior to dialysis, they have high incidence of protein energy malnutrition and micronutrient deficiencies because of the inadequate dietary consumption, because they have nausea and vomiting, gastric upsets, also reduced absorption, adherence to dietary prescriptions that may limit micronutrient-rich foods, and dialysis patients, as we just said, they might have some removal of these micronutrients during the dialysis therapy. Why our patient, usually we prescribe some protein restriction to them to reduce the progression and slow down the progression of CKD, and also it might be helpful to decrease proteinuria, because protein restriction decreases the load of the nitrogen product to the kidney, and also decrease the intraglomerular pressure. So it helps to decrease the degree of proteinuria and slow the progression of CKD a little bit. Also, it reduces the uremic toxins. So it helps to delay the initiation of dialysis a little bit, because the patient symptoms of uremia, especially nausea and vomiting and itching and these things might happen later with the protein restriction. But marked protein restriction will aggravate malnutrition, will decrease the immunity, and decrease the patient quality of life. So we have to be very careful. We can prolong and initiate the dialysis later, maybe for 6 months or a year or something, but we have to make sure that this is not going to happen on the expense of the patient quality of life, the patient's immunity, the patient nutrition status. Otherwise, this might increase the risk.
And also his muscle mass would also be affected.
Right. The patient might have sarcopenia osteosarcopenia, loss of muscle, loss of bone as well, and more importantly, decrease the immunity. So the patient will start dialysis in very bad shape, or maybe even doesn't have the luxury to start dialysis because of increased risk of infection, susceptibility to, opportunistic infection. He might develop one of these life-threatening infection and die. So the balance is very important. Here are key literature regarding the management of nutrition status in dialysis patients. Let's do another question, Aliaa. Do you want to read it?
Sure. Which one of the following statements regarding protein energy wasting in kidney diseases is incorrect? Protein energy wasting is only caused by inadequate protein intake. Protein energy wasting is caused by both inadequate protein and energy intake. Protein energy wasting results in loss of a patient's muscle and fat. Protein energy wasting may lead to increased frailty, susceptibility to illness, premature death. Protein energy wasting is more common in patients requiring renal replacement therapy. I believe the wrong answer is A, because it's not just about inadequate protein intake, it's also inadequate nutrition and energy. So I would go with A.
Very nice. That's very correct. So protein energy malnutrition include both the protein and the energy parts, not only limited to the protein intake. So the protein energy malnutrition is usually caused by inadequate protein and or energy intake. This results in loss of muscle and loss of fat as well, but usually there is disproportionate loss of muscle compared to fat. So these patients lose more muscle, lose protein, and the protein is the main component of the muscle, and also it's very helpful to build up the bone. So they lose, both muscles and bone, and they develop what we call osteosarcopenia. This leads to increased frailty, susceptibility to infection and illnesses, increased cardiovascular, morbidities and mortalities with premature death as well. Several studies have suggested that the worldwide prevalence of protein energy malnutrition is 11 to 54% in patients with CKD prior to dialysis, and this risk might go a little bit higher, 28 to 54% in dialysis patients. Causes of protein energy malnutrition in CKD patients is mainly because of decreased appetite, dietary restriction, inflammation, catabolic state, metabolic acidosis, and dialysis-related nutrient losses. Effective management include nutritional support, adequate protein and calorie intake, tailored dietary counseling, and addressing factors that contribute to inflammation and hypercatabolic status. Here is the guidelines that was published this year in the Kidney International, the KDIGO guidelines. There's a 2024 guidelines for diet management in CKD patients. They said advise people with CKD to adopt healthy and diverse diets with higher consumption of plant-based diet compared to animal-based food, and a lower consumption of ultra-processed food. So be very careful about processed, ultra-processed food when you go to McDonald's, when you go to KFC, and this fast food is not good. The additive part of the food and the preservative are very risky, especially for our CKD patient. And they also said use a renal dietitian or accredited nutritionist or nutritional provider to educate and encourage CKD patients about dietary adaptation, not only about the protein intake and calorie intake, but also about salt intake, phosphorus, potassium. And we have to tailor this and to precisely and individualize and personalize our approach to the degree of malnutrition, the assessment of nutrition status, the degree of proteinuria, if the patient is hypercatabolic or not, if the patient is on dialysis or not. When it comes to protein intake, they said that we suggest maintaining a protein intake of 0.8 gram per kilogram body weight in adults with CKD 3 to 5. That's very essential, 0.8 So if the patient has, 60 kilos, so on average will be 50 grams a day. Maybe if the patient have 80 kilos, so the need will be a little bit above 60, 65 grams a day. They also recommended to avoid high protein intake more than 1.3, okay, gram per kilogram in adults with CKD at risk of progression. So prior to dialysis, try not to give a lot of protein to slow down the progression. In adults with CKD who are willing to or able to or at risk of kidney failure, consider prescribing under close supervision a very low protein with keto analogs or amino acid. So that's kind of new to the KDIGO recommendation. You can give the patient very low protein intake, 0.3 to 0.4 to decrease the nitrogenous end product and the uremic symptoms. On top of this, you need to give 0.6 gram per kilogram of keto analogs or essential amino acids. This has huge financial burden. If you are giving keto analogs 0.6 gram per kilogram, it means that you need about 30 grams of keto acids. Very expensive. So again, we have to weigh the benefit and the cost here.
And that's why they said if he's willing and able. That's why they specified.
Yeah, and they said also under close supervision. So again, this is not something that we recommend for all of our patients. It has to be individualized. We have to make sure that the patient can afford it and also under close supervision. Don't prescribe low or very low protein diet in metabolically unstable patients with CKD. And there is special consideration for children and for elderly patients. So for children, this protein restriction is not advocated, it's not advised, and instead we should give the higher intake of protein. So they said don't restrict the protein intake in children with CKD because of the risk of growth retardation. The target protein and energy intake in children with CKD 2 to 5 should be at the upper end of the normal range of healthy children. So compared to healthy children, you should be on the upper range of those to enhance and promote optimal growth. When it comes to elderly, they said in older adults with underlying conditions such as virility or sarcopenia, consider high protein and calorie dietary targets. So no restriction in elderly, especially if their life span is not great. So don't be very strict. Don't restrict the protein and energy too much for elderly patients and for children as well. So the KDIGO guidelines for CKD management was published this year in Kidney International. It's very, very helpful. It's long, but it's very helpful to read it. Okay, another question for you, Aliaa. Can you read it?
Okay. A 56-year-old male patient with no prior medical history was admitted to the ICU with AKI and neurosepsis. CRRT was started because of oliguric AKI, volume overload, and severe metabolic acidosis. What would be the target protein intake for this patient? 0.55 to 0.6 or 0.8 to 1 gram per kg per day? 1 to 1.2, 1.3 to 1.5, 1.5 to 1.7. I think we all agree that a patient that has no prior medical history and on CRRT and has urosepsis, he should not have protein restriction because this is a catabolic state. So I would go with E as a normal individual.
Very nice. That's a correct answer. So the recommended protein intake in AKI patients depends on two things. If the patient is hypercatabolic or not, if the patient is on dialysis and what dialysis modality is the patient on. So if the patient is not on dialysis and not hypercatabolic, so the advised or the target protein intake is 0.8 to 1 gram per kilogram per day. If the patient doesn't require dialysis but is hypercatabolic, the recommended protein intake is 1 gram to 1.3 gram per kilogram per day. For patients on dialysis, either CRRT or intermittent dialysis, they are usually catabolic, so patient with severe degree of AKI on dialysis, per se, they are hypercatabolic. So if they require intermittent dialysis, they need 1.3 to 1.5 gram per kilogram per day. If they are on CRRT, they need higher, much higher, even compared to normal population because of the removal of this protein and the nutrients through the slow but efficient dialysis. So they need 1.5 to 1.7 gram per kilogram of protein a day. Here is the reference. It's ESBN, the European Society of Parenteral and Enteral Nutrition recommendation. So that's for AKI patients. So remember, CKD usually around 0.8 gram per kilogram per day. AKI is very different. We don't do restriction and usually need either good amount or super amount of protein intake because they are hypercatabolic. Another question for you, Aliaa.
Okay, which one of the following statements regarding obesity in CKD patients is most correct? Obesity is now the most common nutritional abnormality in all stages of CKD. Obesity is the least important risk factor for the development and progression of CKD. Obesity in the CKD population clearly shows a decline trend. Obesity is associated with downward trends in kidney transplant recipients. Obesity is associated with downward trends in patients with initiating dialysis. The most correct, I believe, would be A, as it's a common nutritional abnormality in all stages.
Very nice, very nice. That's the correct answer. So obesity is now the most common nutritional disorder than protein energy malnutrition in all stages of CKD, especially in the developed countries. Again, when it comes to the developing countries, I'm very sure that protein energy wasting will be more common. However, we are lacking good studies to prove this concept. Obesity is an important major risk factor for progression of CKD and also for the outcome of CKD. Obesity in CKD population clearly shows a rising trend, as we mentioned. So between 2011 to 2014, the prevalence was about 44% among CKD stage 3 to 5 in USA population, with half of such individuals having severe obesity. This means that they have BMI of more than 35. This represents a 5% point rise over the last decade. So there is upward trend in the obesity in general population and also in CKD patients and in dialysis and also in transplant population. So all of our population, we are facing now a problem with obesity. Such trends are likely to contribute at least into a near future as prevalence of obesity in the overall population continues to rise. Similar upward trend has been seen in kidney transplant patients and dialysis patients as well. The percentage of CKD patients with obesity also correlates with the stage of the CKD. So the prevalence in CKD stage 1, the prevalence of obesity is about 37%, and it increases stage by stage. It's up to 41% in CKD stage 4. Obese patients with CKD stage 3 and 4 appear to have higher risk of CKD progression. It might be directly related. It's just an association, not a causation. It might be attributed to the obesity itself as a metabolic syndrome, but it could be also because these patients have poor control of their diabetes or blood pressure or other risk factor that can contribute to the rapid progression of the CKD. These patients with CKD stage 5 with BMI of 30 or more were less likely to receive kidney transplant. Of course, obese patients, especially if they have marked obesity with BMI of 30, they have much lower chance of getting a kidney transplant. And of course, the kidney transplant complications are more common among obese patients. Just one more, and here is the references, 2024, 2024 references. So please, if you are interested in getting more information, go ahead and read this article. Last question for you, Aliaa.
Okay. What does the term obesity paradox in dialysis patients mean? Obese dialysis patients have increased risk of various health complications. Dialysis patients with higher BMI have better survival rates compared to those with lower BMI. Obese dialysis patients have increased risk of fragility fractures. Inflammation and low dialysate glucose concentration induces weight gain. Obese dialysis patients have less energy reserves. Okay, the term obesity paradox, it means when the dialysis patients have higher BMI, they have better survival rates compared to those with lower BMI, and that's why it's called paradox, because it was unexpected, but because probably they have good nutrition status and good health and good quality of life.
Very nice. So yeah, compared to general population, when we see all the time that obese patients, they have higher chance of cardiovascular disease and cardiovascular mortality. When it comes to dialysis patient, obese patient compared to those with low BMI, they have better survival, and this is what we call obesity paradox. We have to understand this concept.
I think it means also they're having good dialysis outcome, good urea reduction, so their appetite is better.
Could be, could reflect better dialysis adequacy, but it's multifactorial, and there is a problem here because the BMI is could be a little bit tricky, especially in dialysis patients, because several factors. But the reason behind obesity paradox in dialysis patients, it might be they have better survival because they have better nutritional reserve. So, as we know that dialysis patients are hypercatabolic, and this can lead to loss of muscle and protein wasting. So having a higher body fat and muscle mass can provide a nutritional buffer, especially if the patient gets sick or something. You will have better immunity, or better nutritional status, so he can, withstand or can tolerate any, challenges, infections, admission with cardiovascular disease or pulmonary problem or GI complication. They can tolerate it better. And also they have energy reserve during illnesses because the higher BMI is the higher energy reserve that can sustain prolonged illness. Patients with lower BMI are usually associated with hypoalbuminemia, anemia, acidosis, fluid imbalance, and all of these. So the impact might not strictly related to the obesity itself, but it could be also related to other factors as confounders. So while obesity paradox suggests that the higher BMI might confer survival advantage in dialysis patient, it's important to approach this very carefully, and I'm going to tell you why. So not all forms of obesity are the same or are equal, because obesity could be related to waist obesity, or it could be increased BMI because of increased muscle mass, right? And also because obesity is a metabolic syndrome that's associated with heart disease, diabetes, that has been associated with worse outcome. So abdominal obesity or waist obesity could be more deleterious even in dialysis patients. So several studies have shown that the higher waist to hip ratio is associated with higher mortality even in dialysis patients. So here is a point. When we say obese patient, we usually use BMI, and BMI doesn't usually look to the muscle mass or the fat or the bone content, just look to the weight, whatever the weight is. It could be muscle, could be fat, it could be bone or water, right? So it's a relationship between weight and height. So it's the weight over the square of the height. So we say the patient is underweight if the BMI is less than 18.5, normal weight if the BMI is between 18.5 to 24.9, overweight between 25 to less than 30. If the patient is more than 30, BMI, we call it obesity. So 30 to less than 35 is mild obesity, moderate between 35 and less than 40. And if it is over 40, we call it marked or morbid obesity. So it doesn't, look to the differential compartment between fat tissue, lean, which is the muscle, and bone mass. And in patients with CKD, they might lose more muscle, they might have more fat, they might have more water, they might lose more bone. So there is no proportional loss or proportional gain. So the equation here might be tricky. So depending only on the BMI, especially in dialysis patients, might give us a false impression. So if you are accounting for the high fat tissue, this might be associated with decreased mortality. But if you are looking to the high waist to hip ratio, or what we call abdominal obesity or waist obesity, or if you are looking for the waist circumference rather than the triceps folds, the BMI by DEXA scan or the bioimpedance technique, you can have increased mortality with obesity. So that's a little bit tricky. Again, here are references if you want to see this concept of obesity paradox and improved survival in obese patients in dialysis. That's very important term and concept to understand, but it has a lot of fallacies, so we have to be very careful. That's all questions and answers. Thank you so much, Aliaa, for your help answering these questions. And hopefully we'll see you again trying to answer more and more questions.